Welcome back to the Fit Des Moines podcast, your go-to source for health, fitness, and active living in the Des Moines area. Today's guest is Dr. Jason Sullivan, Milwaukee native and board-certified orthopedic surgeon specializing in sports medicine right here in the metro. His path here is pretty remarkable. Medical degree from Loyola University's Stritch School of Medicine, orthopedic residency at Loyola University Medical Center, and then a sports medicine fellowship at the Kerlan-Jobe Orthopedic Clinic in Los Angeles, one of the most respected sports medicine institutions in the country. During that fellowship, he served as an assistant team physician for 6 professional organizations: the Lakers, Dodgers, Kings, Ducks, and Angels, along with the PGA Tour and the USC Trojans football program. He's seen what it takes to get elite athletes back to peak performance, and he's now applying that experience to active patients here in central Iowa through minimally invasive restorative orthopedic surgery. He's also a longtime volunteer sideline physician for local high school football teams, which tells you a lot about who he is. Dr. Sullivan, welcome to the show.
Hey, thank you very much, Brian, for having me. I appreciate it.
Yeah, absolutely. I'm really looking forward to this. So, Dr. Sullivan, I thought we'd take a deep dive today and talk about everything ACL. So,
yeah, I'm in, man. And you got to call me Jason, by the way. You got to call me Jason.
I can do that. Well, let's hop right in. ACL is a big topic. I know, especially with athletes, it's something that I think is in the back of their mind. Everyone hopes that they don't have to go through it, but we see it a lot. Tell us a little bit about your experience with ACLs, with surgery. How many do you see a year?
That's a good question. I don't know that we ever counted. I think, I probably fixed around 100 or more a year. And the interesting thing is, like, for me, all these injuries are devastating for who's in front of you to some degree, but the ACL injury emotionally seems like it's one of the bigger hits to the patient that you're seeing, and a lot of times it's teenagers, high school athletes, collegiate athletes, even, people in our age range who are, they're trying to stay active. They're trying to reach a goal, and maybe they've reached it, maybe they haven't. And then something happens, right? They have an injury, and there's always it always starts with a little bit of doubt. Like, something happened here, but I think I'm okay, and so then when they come to see us in clinic, either they have an MRI or they don't. And it's very difficult to navigate. How much do you already understand about your injury? The people that come in knowing they have an ACL tear are usually easier to kind of set the table as to, hey, where are we going from here? But those that don't know it yet, it is quite a shock, So it's a delicate conversation that takes a lot of time in clinic, but it is something I'm passionate about, partly because you get to see them 9 to 12 months later. And a lot of these kids are local, or adults are local, and then you get to see them, they go from at the bottom, and then all of a sudden they're smiling, they're at the top, they're back to where they wanted to be. And so it's a very gratifying thing to take care of, but it is initially, like, you kind of feel it yourself. You're like, this is, you kind of wear it around the rest of the day because it's a big deal to them,
Yeah. I'm really glad you brought that up. Because that's something I've seen it a lot lately. I mean, I've seen it throughout my career, but just become more and more aware of that the longer I practice, right? There's such a mental aspect, whether, regardless of surgery, but the ACL is definitely, it's a huge impact on people. And I think it's that doubt of, what's their life going to look like afterwards. And especially for the young athletes, like you talked about, are they going to get back to playing the sport that they were before? And some of those athletes have scholarships on the line. So, are they going to be able to get back to a level where they can play and still earn that scholarship? And I think, like you said, you can kind of feel the weight of that sometimes.
Yeah, 100%. I'm guessing that you, ahead of time, when you do some prehab with them and things like that, I'm guessing a lot of what you do is kind of walk them through, like, hey, here's what it's going to be. And then it's probably a little bit of like psychology and coaching, right? And getting them, first of all, you mourn the injury, right? And then once you get past that, then you start talking about, how do we build from here? And I routinely send most of my kids for some semblance of prehab, local or wherever they plan to go for PT, because I think establishing that rapport with someone like yourself is a huge deal heading into surgery. It's one less question mark, when they head into that big day. And then we know the mental component might even be, at the end of the road, the thing that holds people back more than the physical component. I don't know if you see that yourself, but
yeah, for sure. Yeah. I have. I'll never forget this. This is when, for everyone that's listening and for yourself, Jason, out of school, I got a commission in the Navy as a physical therapist, and so I did that for 5 years. I'll never forget. It was in Okinawa, Japan, working with this recon Marine, so pretty high level Marine, and ACL patient. And I said, okay, well, today we're going to do some hop testing, single leg hops. We're going to see where you're at. And I said, all right, just line up. We had this doorway where we that was the starting line, and then had it marked out. And he wouldn't go. And I couldn't figure out why. I'm like, come on, dude. Like, let's go. Let's get it. This is on the road. Like, this isn't a big deal. You've been rehabbing this thing. Let's go. Let's get it. And he was just kind of sweating bullets there. And he finally just looked up at me and he said, sir, I'd rather get shot at than jump on this leg right now.
Are you serious?
I was like, yeah, it kind of like, that kind of took me back. I was like, whoa, like, I don't think I had ever really thought about it like that until he said that. And I was like, wow, that's pretty intense.
Yeah, I don't think you could put yourself in their shoes until
Right.
have gone through it yourself. And I'm fortunate enough not to have had a big injury. I don't know if you've had a big orthopedic injury, but it takes a long time to get whole again,
Right. Yeah. 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 I was gonna say I've had some injuries, nothing I've had to have surgery for, and so I've obviously seen it over the last 12 years, but haven't had to like live that. So
Yeah.
Kind of walk us through. Say a patient has an injury, they're coming to you. I guess you can outline it whether they know they've got an ACL tear or whether or not. But kind of walk us through the process. What's that look like for a patient?
Yeah. So typically we'll see someone within a week or so of their injury. They may have been somewhere else. They may have come in with imaging. Let's say that we know it's an ACL injury. I always start by kind of talking to them, understanding, where are they coming from? Where do they go to school? What do they like to do? What's their occupation? To try and figure out, okay, what kind of activities is this person involved in and what's important to them. And then we kind of walk down through a physical examination and, if they're 2 weeks out, a lot of times people come in and say, hey, my knee's feeling better, as you probably know, right? Like the swelling goes away, they can walk. You can even run in a straight line without your ACL, but it's that next cutting pivoting event that you're trying to avoid, a pivot shift or something that would cause further harm, right? So you kind of walk them through the physical exam. You let them know, hey, your ACL feels unstable. You have the MRI as well. But to me, there's like, in my head, like, it's like, okay, we have an ACL tear. What else do we have going on here, right? So we know that with ACL tears, 40, 50% or higher have some type of other pathology, whether it be a medial or lateral meniscus tear, the shock absorbers on the inside or outside of your knee. The MCL, the ligament on the inside of your knee, is commonly stretched and rarely needs any type of surgery unless it's a really bad complete tear off of your tibia. So we usually treat those conservatively, but the meniscus come in all sorts of varieties. So there's some meniscus tears that are simple and you're like, hey, you're going to lose a little meniscus tissue and your ACL surgery is going to carry on like normal. And then there are big meniscus tears where, hey, we need to salvage this meniscus and repair this. And so your recovery in the first 2-3 months is going to look a lot different than if it was just your ACL. So everyone comes in and they have had a friend or someone they know that has had an ACL surgery, and they're always comparing it to that. But I caution them. I'm like, I really think that this is not a one size fits all injury, and it is completely individualized, So we start by kind of breaking that down, and do not compare yourself to anyone else. And then we kind of outline, okay, in my mind, an ACL tear is a surgical problem for the cutting pivot activities you want to do. If you're 75 years old and you somehow sustain an ACL injury, we'll talk about, are there some strategies we can avoid surgery here? But I even have some 60-year-olds that come in and say, I was skiing, I tore my ACL. Don't tell me I'm too old. We're fixing this, So I'm guessing in your experience, you see most of these get surgery and progress on.
Yeah, for sure. I think there's the large percentage of that. And I was going to ask you even, is there a certain patient demographic? Obviously, the older patient, like you mentioned, might not be a good fit, but is there a time where a younger patient might not be a good fit for an ACL repair?
I've had a few
Reconstruction.
Kids that'll come in and they'll say, like, their parents will be like, they love this sport. This is their senior year. Can they, they're on the bench for the basketball team. Can they go back in a brace and get through the year? And I think in the right scenario, you can kind of work with them and say, hey, here's your risks. I'm never someone who says, like, you can absolutely not do this. I think I'm an advisor, more or less, is the way I look at it, right?
Yeah,
Unless you're in charge of a team, contractually in charge of a team, like Drake University, I take care of their athletes. Like I feel almost contractually obliged to be like, hey, we're not playing tennis on an ACL injury here. And if a high school kid comes to me, the parents are like, they have 4 more weeks. They've been rehabbing the knee. What can we do? We can kind of work within a time frame there. But I do think the data shows that the longer you go before you have an ACL reconstruction, the greater chance there is of disruption of some type of cartilage injury, making a meniscus tear worse. And to me, those are the things that probably lead to arthritis more so than the ACL reconstruction itself. And so we're really restoring the ACL so you can get back to activity, but also to protect those vital structures that keep your cartilage healthy in your knee. So when you're 60, 70, 80, you're living a great life, you're active, and you're able to do all those things.
Yeah, and I think that's something you just touched on was a big question that we always get too is, am I doomed to have arthritis now that I've had this ACL tear? And so
I mean, a lot of the data says that, maybe graft choice matters a little bit. Maybe what other injuries happened at the time matter a little bit. But I think that probably the initial insult and the bone bruise that you have, that may set off a cascade 10 or 20 years later that leads to some cartilage thinning. And there's some inflammatory markers that are triggered in an ACL setting, and the knee doesn't like that. And so there may be some things that are set in process that don't manifest for 15 or 20 years. But I think all in all, with some newer techniques, I think we're doing well enough that you can see people potentially not develop arthritis with an ACL tear.
nice. So let's keep walking down, patient comes in, we've determined, done the physical exam, we've determined there's an ACL tear.
Yeah.
What's next from there?
So the big question that we need to get through is, what do we use for this reconstruction? Traditionally, I say there's basically four things you can use if we're talking about a reconstruction, and we can get into the idea of repair and discuss that a little bit if you'd want to at some point. But let's say we're doing a reconstruction using something else to make a new ACL. In my hands, 90 to 95% of the time, I'm usually recommending autograft, meaning using their own tissue. And there's three different autografts that I think are all valuable in different contexts. So you have the hamstring tendons or tendon, you have the quad tendon, and then you have the patellar tendon. And so I use all three intentionally because I realized pretty early on, and being in LA, it's a very concierge world and people do their own research and they don't really want to be told what to do. So if someone comes in and says, hey, I did my research and I want a quad tendon ACL, it's a good graft. You can have a great result with a quad tendon ACL. So why would I bicker with them? I have my biases in certain contexts, young kids, cutting pivoting athletes. I have a bias in my middle age, group that not doing cutting pivoting activities anymore. I think it opens up the variety a little bit more. And then in your 60-year-olds, if they're like, hey, I don't want a graft harvest, then you think, okay, the fourth type is allograft. That's using someone else's tissue. And I think it's perfectly reasonable in that context. So I think you got to be versatile in this world. And so I like to understand new techniques. And I think we have it all down to where if you pick one of the three grafts, like you're getting the same kind of procedure, because what people don't realize is what's really important is getting the anatomy restored, right? You can put any graft you want in, and if you put the tunnels in the incorrect position, they're going to have some type of impingement, or they're not going to have rotational stability of their knee. So I think really getting the tunnels right and going to a doctor you trust is the most important thing. I think graft is probably way further down the list, but it seems to be the thing that we get to when we spend the most time on.
Yeah, I would agree. Everyone wants to talk about their graft type, and just, I'm sure orthopedic surgeons, physical therapists are this way too. They've all got their favorites and what they like to see. Why don't we, since we're on the topic, why don't we take a deep dive into those and talk about the pros and cons of each, and when you might recommend one versus the other?
Yeah, so it's interesting. When I came to town 13 years ago, someone asked me, this is when patellar tendon and hamstring were probably the two most commonly utilized grafts. And someone was like, hey, what do you prefer to use? And I was like, well, for a young cutting pivot athlete, I think patellar tendon is I like it. I think it's really nice. I think it gives you nice stability. And I think that anterior knee pain was a little bit over observed. And I think if you close the tendon in layers and bone graft in where you took the plug from, I think they do really well. And a person told me, he's like, hey, you'll never see an ACL in this town without opinion. It's a very hamstring dominant town. I said, all right, well, I'll try my best. I said, I like hamstring too. I don't have a problem with it. So what I tell people is this. I say, the patellar tendon, the plus side of the patellar tendon is we can take the size of tissue that we want. And we know in studies that cross-sectional diameter matters in terms of re-tear rates. If you get a 7 millimeter graft, you probably have a higher likelihood of a re-rupture than if you get a 10 millimeter graft in diameter. So I like that element of the patellar tendon procedure. You also take bone plugs on either end. And so if you figure out how to work with whatever length the patellar tendon is, sometimes there's a little mismatch, but if you're clever with it, you can get it anchored on either side and you can get bone to bone healing, which gives the patient maybe a little sense of increased stability initially. The downside is if you care about your incision, you will have a 5 to 6 centimeter, longitudinal incision on the front of your knee. And I'd say 1 in 20 people have anterior knee pain or patellar tendonitis and things like that. I think it usually runs its course and burns itself out. But that's what I kind of tell them as my brief spiel on patellar tendon. Hamstring tendon, I say you can do one of two things. You can either harvest both hamstrings and quadruple them over, or you can take one slip of hamstring and burrito it and fold it over 4 times. And in either event, you usually get your way to an 8 millimeter graft or maybe a 9. And that's perfectly adequate for most people. There are some times you harvest the hamstring and you're just a little dissatisfied with, this is a little smaller than I was hoping it would be. And so that's when maybe you need to augment it with allograft or whatever it may be, but you can still get them to where you want to be. The downside of taking the hamstring is that you can have some weakness with flexion of your knee at like a really high flexion angle, but no one's really doing that functionally. Who's flexing their knee past 120 degrees? No one. So no one really knows that unless they're really in tune with their body. And every once in a while, people will kind of recurrently pull that hamstring and feel it in the back of their thigh, but it's a pretty benign graft to take. I don't like taking it sometimes when there's a significant injury to the medial side of the knee, like an MCL, because I think the hamstring is a secondary stabilizer of your MCL. So like if you have a grade 3, a really bad MCL and it's really unstable, then I sometimes I think twice, but it's a really good graft too. And I've had plenty of patients do awesome with it. The third graft is the quad tendon, which honestly is becoming very popular. I think most guys coming out of sports fellowship training are seeing a lot of quad. And so they're doing a lot of quad. The advantage of the quad tendon is you can take a 10 millimeter strip and the cross-sectional area is greater probably than that of the patellar tendon. So tensile wise is probably a little stronger. It's all soft tissue, so you have to put it in the sockets and you have to allow that bone to soft tissue healing to happen. But you can actually brace across it with a piece of rope as well and really stabilize that knee. So that's a nice part of the procedure. The downside of quad is if you look at long-term studies, some even out to a year, especially in females, the way they land and the way they absorb stress with their quad can still be altered even out to a year or so. But long-term studies show that they eventually get there and normalizes. So quad atrophy would be the biggest thing you worry about because obviously you're taking a 6.5 or 7 centimeter strip of that central part of the quad. So that's kind of the general conversation I have. And then I usually ask them, I say, hey, tell me what you've learned. Because I'd say 50% or more have they've been reading, they've been doing the research. And I like that because then we have an informed conversation. And there's no reason to argue about these things. Like my job is to tell them the pros and cons, and to a certain degree, they can choose what they want if they have strong convictions.
Yeah, absolutely. I think even when people come into physical therapy, like they're well informed nowadays. Like everything's on the internet and you can find it pretty quickly. So I like that take. I like that take on it. So once we've picked the graft out, we've decided surgery is the option. Kind of walk us through surgery day and then what that looks like immediately afterwards.
Yeah, so surgery day for them, it's a big event. It's for us, it's about an hour procedure or less, but they have to get there early. They have to get there checked in. Once they're situated with an IV, our anesthesiologist get them a nerve block, called an adductor canal block, and then they also do what's called an IPAC block, which is blocking kind of the capsule in the back of the knee. And to the best of our knowledge, that does a pretty good job of covering the knee while not knocking out the quad. So most of my ACLs, I want them putting full weight down right away in a brace afterwards. So we fit them for that brace as well, and we put them in that after surgery. So I usually keep them straight in that brace, let them put full weight down with crutches, and then they come see us about a week or so later. We kind of look at the dressing, refit the brace and everything. Therapy starts right away after that. In the meantime, they've been using the CPM machine and doing some heel slides and some quad exercises. And then they're already plugged in with their therapist, typically with prehab. So then they get rolling right away there. And then it's kind of off to the races. The scenario that's hard is when you found a meniscus tear you didn't expect, or something was a little worse than you thought, and you do a meniscus repair, and then you say, that tissue's pretty delicate, and we're going to have to take a little bit of weight off it. And so sometimes a month of weight, minimal weight bearing, and then after that kind of slowly progressing to being full weight bearing by, 2 to 3 months is necessary. And that really hinders people's ability just to get around, go to class, go to work. But we think it might be necessary in some context of a meniscus repair for success of that repair. those are the kind of the big things we discuss. The day of surgery tends to go pretty smoothly. Usually they get their mind around it pretty quick. It's one of those, it's the biggest shock when it happens, but it's also the people that like the human ability to flip the switch and be like, all right, we're ready to go. And a lot of credit is to you guys because you do a lot of counseling behind the scenes to say, hey, you can do this, we're going to get you through this. And so with a team behind them, it goes a lot better.
Absolutely. There's two things you talked about there that I want to hit on a little bit. It sounds like you're in favor of them, but I see it go both ways here. So one was the brace and then CPM. So I've seen some surgeons where they're like, nope, research says, no, we don't need that brace. Knee's stable, let's go. And I've seen others that are the opposites, well, maybe they don't need it. The surgery's good, but it's more of an indicator for other people. I don't know. What's your take on that? What's the research show? What are your thoughts there? And then the second one, go ahead. We'll hit the second one next.
So bracing, I think that for me, post-op bracing immediately is a way of kind of slowing the patient down, holding them back, preventing the oops, I was asleep, I got out of bed, I had to go to the bathroom, I took a misstep, I didn't have a brace on, I'm post-op day 2. To some extent, it's protecting the patient from themselves, maybe. I don't like to use it longer than we need to. And the second they have quad control and can do a straight leg raise, and they can demonstrate in clinic with you, they can walk, they can come out of the brace. If they have a meniscus tear, I think that the brace is still a nice reminder, hey, we're going to be non-weight bearing for a little while here. I have an injury. And it's just a constant kind of proprioceptive feedback, like, okay, we're protecting this leg for a little longer. I think, I could be wrong. I think most people post-op after an ACL surgery use a brace right away. Now, when you brace long term is probably maybe the more controversial thing. Return to sport braces and things like that. I usually offer some semblance of a return to sport brace, like you'd see like a quarterback wearing on their, on their plant leg, for a DN coming in. I say, hey, this isn't going to prevent a re-tear. If you play a contact sport, if you're on the O line or the D line, there's zero downside in using this. It's going to help protect you in the coronal plane from like an MCL injury, or it'll just protect you from one variable. And some people are like, hey, I want to go hiking, and they're 4 months out from an ACL, and I'm like, they probably could, but it's uneven ground. Maybe that's when they use the smaller brace. But I've kind of gone away from telling people they have to do that because I don't think we have any evidence it prevents recurrence. And most high-level athletes, like, they look at me and they're like, dude, I'm not using this. I'm not, when I go back, I'm not wearing this. And so then it's kind of like, okay, you hear enough people tell you that and you kind of say, okay, but by the same token, I do think, and you tell me if you've noticed this, but I do think that 13 years ago, I was like, at 6 months, hey, go for it. Do whatever you want to do. But honestly, like, I feel like as we advance, we have more objective measures of when someone can return. And I think it's more like an 8-9 month injury. If you look like the pros and high level collegiates, like sometimes 9 months to a year. So I think maybe we're protecting people for longer. And that bridge of having a brace, maybe when they go back, is no longer as necessary as we may once have thought it to be.
Yeah, I just had that conversation with a patient the other day. They said, this is going to be 6 months. And I said, well, actually, you're going to be feeling great by 6 months. But research now is showing if we can push that out to 9 months or longer, like you said, 9 months to a year, our rate of re-injury is much lower than if we return to sport at that 6 month mark. So yeah, I agree. And like I would say, like you said, most of the surgeons I've worked with will do immediate post-op bracing, especially for the first couple weeks. And like you said, the meniscus tear is a whole different story. Like that really changes the game.
Yeah.
So, and I've fast forwarding then to return to sport. I've seen that go both ways where, especially linemen, they're bracing. I've seen quarterbacks as well. Just kind of depends, but it seems like we've kind of shifted away from, needing that brace long term.
I think you're probably right. I mean, at least that's the dynamic I've seen. And it mostly comes patient driven, like you're not going to, if someone tells you they're not going to wear it, no matter what you tell them, okay, well, let's work around this, So, I think you're going to get to the CPM thing too. The question on that.
Yeah.
About using CPM.
That was my other question.
Yeah. So honestly, there's no scientific evidence you need a CPM after an ACL. For me, it's that bridge for the first 2 weeks. I think cartilage likes motion. Okay. And so it's a way of every day guaranteeing a couple times a day for half an hour that the knee joint's moving. And I tell them, hey, here's what extension is, and we got to ensure extension. But it gets working on their flexion. I think also a lot of patients feel like I'm just sitting around. I'm lazy. I'm not doing anything. So I feel like they feel like they're enrolled in their own care that way. And they can't come see you every day. That's not a feasible thing. For the first 7 to 14 days, I do that. And then, with some cold compression and things like that, I think for me, patients tend to like it, and we've been able to keep it cost effective for them. And so honestly, I've stuck with it, but there are no studies that show that, like, if you don't use a CPM, you're not a bad doctor. If you do use one, maybe you're not paying attention to literature that says it doesn't matter. But honestly, to me, it's something that seems to set up nicely for my patients. I've just stuck with it.
Yeah, yeah, it's funny that you mentioned that, because I would say a majority of physical therapists that I know are against CPMs, but a majority of the patients that come in absolutely love them and they enjoy using them. So I don't see what the harm is either. If it's helpful, I don't think they're hurting anything. So why not get the joint
Yeah, I mean,
moving?
if it becomes where it's not cost effective, then yeah, you got to ditch it. But if you can
Sure.
work out some agreement with the companies, and say, hey, my patient doesn't see more than X out of pocket, and then it seems to be like, okay, I don't see a downside,
Yeah,
so.
yeah, yeah. And like you said too, motion's lotion. And so getting that joint moving, kind of feeding some of that tissue. Even the course I was telling you about before we started this podcast, the neurodynamics course, they were talking about fluid dynamics within nerves and how they like fluid. And so getting some of that movement in there too. So it's that tissue it's meant to have
Yeah,
that in there, and
yeah,
movement's one way to do it. So
yep, percent.
yeah. So let's talk about, post surgery. We've kind of talked about we're getting people up, we're getting weight bearing through that limb, which I think I'm obviously for that. But patient wise, it seems like I don't know if people have quite caught up to that. A lot of people are surprised, I think, that we're getting people up right away. We're putting weight through it. We're moving.
I think if you set that as an expectation, if you,
Sure.
we do a lot of, when I leave the room, I usually tell them, hey, my PA here, who's with me every day, is going to spend 5 or 10 more minutes talking about the intricacies of, the first 7 days after surgery and all that. And so
Yeah.
we usually hammer it as an expectation. And so then I think they're like, then they think they can trust it. There's a few people that come in and very guarded, but, the weight bearing thing seems to, once they do it once or twice, they don't seem to be, and then I have some kids that come in for the post-op, no crutches in sight, skipping down the hall, ready to be done with the brace. So, everyone,
Yeah.
my absolute best patients are the lucky non-compliant patients. I don't know if that makes sense to you, but
Yeah.
the ones that just, something with their biology, it happens sooner. They kind of make their own rules up and like they're off to the races and they're happy.
Right.
And I can't explain it, but
Yeah. Yeah. It's that
some people
patient
get
that's
that.
like, it's like they're not following a single thing
Yeah.
and they're
And they're
doing
killing it.
phenomenal.
Yeah.
Yeah.
They're absolutely killing it.
Yeah.
Happens
Yeah.
all the time.
So, we're going to get physical therapy started. We're going to get that quad control back. But then what's it look like? What's the care? They're going to see us every day, or not every day, but they're going to see us several times a week there. So what's the follow-up care with you look like after
So I
that?
see everybody 8 or 9 days after surgery. I see everyone then at usually 5 to 6 weeks, 3 months, and then typically 6 months. If someone's struggling, we see them through, we see them at 9 months. Most people at their 3-month visit are looking at me like, I can't golf. I can't, what are you saying here? And so if we kind of outline the next 3 to 6 months with them, I don't want to charge them for a visit. I say, hey, if you have any issues, just come on in. We can talk or send me a task and we can call you. But I don't routinely make people see me at 6, like especially my adults that are like active enthusiasts, but not necessarily getting back to a team sport. My team sport, usually the coach or the AD or someone wants a blessing, right, of some variety. And so then it's always good to do that. But it's gotten trickier because usually when I see people at 6, when they look great, I'm like, all right, let's go for it. But now I'm kind of like, okay, the risk of injury to your other knee is higher now than it would be in another 6 weeks, So what do you think about? So I try and frame it like some people think like it's a failure of modern medicine. Like, how could I not be back at 3 months? Why is it taking longer now? I think we just know so much more. We have so many metrics of objectively measuring their strength and doing these return to sport tests and all that. And you could speak to those things. I'm sure even at a year, sometimes you're like, well, they still have a deficit, but let's, at some point you just got to cut it loose and go for it. Right.
Right. Yeah. And that's where you talked about earlier too. Like everyone's different and you can't cookie cutter. You can't cookie cutter the surgery. You can't cookie cutter the rehab. Everyone's so much different and their progress is different. And I think the hard part is, a lot of people see these professional athletes getting back to playing very, very quickly. I think of like Adrian Peterson. And so
that's the one that always comes up,
right.
You just don't, you don't
Exactly.
know what else was used, in conjunction. I get asked all the time about, what can I do to speed this up? What peptide do I need to take? Do you get asked about peptides all the time? You must.
Absolutely. Yep.
Okay.
Yep.
And it's an intriguing, there are effective peptides out there already. We know that, right? GLP-1s, right? I mean, that's a perfect example. I mean, it targets something and it does what it's meant to do. The ones for like building muscle and, anabolic activity, I don't understand them as much. So I tell them, hey, at your own risk, you can do whatever you want. I'm always a little wary of the cheat codes. I don't understand them enough yet. And I don't know if we have enough
Sure.
science. They're not regulated, but I'm sure
Right.
someone's going to figure this thing out and it's going to get more advanced.
Yeah. Like BPC 157 is the one that people ask me about a lot. And,
I probably get 3 questions a day about that. And I try and do some research on it. And then I just can't find like the peer reviewed, like level 1 stuff or level 2 that we're used to like kind of quoting or relying on. And so I'm kind of like, okay, level evidence isn't there yet. It's promising, but we don't know enough for me to professionally say you should do it.
Right. Right. And then it's just like the GLPs, they're so easy to get and seem to be pretty affordable. And so I think that's a hard thing too. People can just readily go get them. You don't need a prescription in some cases. So
And initially, wasn't it? You had to see a doctor to get on one, and now it's a little bit of the Wild West. Like things that aren't regulated, they're you just got to proceed with a little bit of caution. But not that it could work perfectly for someone. I don't know enough to tell people to do it or not do it. And that orthopedic, our academy recommendation is we don't have a formal one yet on regularly incorporating that. So I have some patients asking, hey, can you give me some HGH after surgery? And theoretically, I'm like, God, that sounds like an amazing idea, but conceptually, face forward to your patients. You don't know if that's going to cause some type of pituitary tumor or what are the downside, problems that you could be causing just to get someone to heal up a month sooner. I'm not really willing to take that risk lacking the expertise. So I kind of stay out of those conversations.
Right. Yeah. What about things like PRP? Is that something that you do in your practice? And is that something that potentially with ACL or meniscus tear can be beneficial?
Yeah, good questions. We do PRP at DMOS. I do PRP for a few good reasons. I think early arthritis, it's probably a little better than a cortisone or a visco supplementation injection, but fractionally. I think partial tears, maybe there's a role for things, maybe a partial UCL tear, maybe a partial rotator cuff tear. So I do them. And honestly, I start by being fiscally responsible for patients because insurance doesn't cover this. And so you have to charge out of pocket. And then, you do have stem cell clinics in town that do this too. I think we do it responsibly. For a meniscus repair or a tear, and an ACL tear, we don't have any evidence yet that you need to be doing this or telling people that they need to do this. Now, ACL repair, the thing I kind of mentioned at the beginning, I know enough about it. I could execute the procedure. I haven't done it yet because I just don't know who am I going to choose to do that for, because I think the re-tear rates are a little higher. But in repair, you use the plate, PRP and a collagen scaffold and biologics to have both ends of the tissue kind of reopposed, and then you let the body do its thing. But the niche for that is very small. It's kind of like non-contact athlete, older, cartilage has to look good, and then your re-tear rates are no better than a recon, and they fall short in many measures. So it's coming. It's interesting stuff, and that you use patient's biology for that. So that's kind of that's probably the most promising aspect of the biologics field in the ACL is, can you get some of these ACLs to regenerate and become as good as they once were?
And just to clarify, for a repair, you're looking more at like a partial ACL tear versus a full.
So It can be a full, but you need like 10 to 15 millimeters of the stump off of the tibia to be intact,
Got it.
because you got to
Yep.
put stitches through that and through the femoral part and have them envelope into this scaffold. To me, it's like when I go in there, some of these ACLs, it looks like a bomb went off, and you know that it's probably not a great idea. And then some you're like, there's 30% still here. Maybe, most of the posterolateral bundle's intact. A lot of people don't know there's two bundles of the ACL. And so maybe one of the bundles looks pretty good. So there could be a role for that patient. It's always nice to know ahead of time when you're going in. It's a little stickier when you're like, hey, I'm going to have my repair guy here and my recon guy here, and I'm going to have all these reps around, and we're going to decide. Too many variables, and I don't like uh, wasting other people's time. I usually like a plan A and a plan B, and we move, and that works well for me efficiently. So I still haven't figured out the role for repair yet, but I think that we need longer term studies, but it'll be interesting to see where those go in the next 5 or 10 years.
Yeah, I'm glad you mentioned that too, because I was going to ask, can you even see that on an MRI? Sometimes it seems like things hide on MRIs, and so you might not know till you get in there anyways. And so which way are you going to go? Yeah.
It's tricky. I think it's a lot of game time decision, and then I would probably do it in the first patient that comes to me and says, I want to repair. I look at the MRI. It seems reasonable. We would, try it, but it'd have to be middle-aged adult, non-contact. The bar would have to be low. And I think our re-tear rates on reconstruction are pretty good these days. Like you're going to have your failures if you do enough of them. And if you put the ACL in the right spot, you might actually have more failures because the graft is actually seeing the strain that it should see. I think sometimes conventionally, like 20 years ago, some of the techniques were a little more vertical. And I don't think the graft was actually seeing as much strain. So I think maybe re-tear rates were less, but you probably weren't controlling as much. And so rotationally, you get more meniscus injuries post ACL. The ACL looks good, but you have these big flip bucket nail tears in the meniscus and you can't figure out why. It's probably because the ACL isn't constraining the knee as good as you want it to. So I think if you do get an anatomic, you have to be prepared for you're going to have a couple failures out there because you got someone back to the level they're at, and the graft is seeing all of that strain that it should be seeing.
In your experience as well, are most of your patients getting back to high level activities and able to play the sports that they want to play without any hindrance there?
Yeah, I mean, by and large, I would these things like ruin my day. So I haven't been that depressed lately. So I feel like yes, I mean, um, absolutely. Like the expectation is that they are by 9 months to a year, they're back to where they want to be. Whether they're at that level right away probably doesn't matter as much as like their trajectory and if they get there. But yeah, I mean, my expectation, I tell them right away, like we want you to get back to the level you were at, and then we accept any risks that happen at that point because things are going to happen on a turf field playing soccer as a female athlete, right? But if you can get them back and they feel great, then I think their chances of normalized to less than 3-4% or whatever, and then that's the whole goal. You want to be back. Very few people fall short, and sometimes if they fall short, it's almost like they did an internal check, and they're like, "This what I was doing isn't that important to me, and here's where I'm headed." So they just pivot and go in a different direction, and that's fine too.
What's your take on turf fields versus natural grass fields?
That's funny you asked that.
Or
I
do
get
you have
asked
an
that a
opinion?
lot. I inherently you have to think that we went to turf fields because basically they're less maintenance in the long run, right? But there's also like there's less give. Like if you plant on a outdoor grassy field in the EPL and a piece of sod comes up, you're probably not tearing your ACL. But like if you plant on a turf field, like there's only so much give. So I think the turf's gotten better. I think that it used to be horrendous, and I think it's getting better. And I think the evidence points towards it being very minimal, if even obvious at all. And when you just look at it, you're like, there has to be some variance in the turf, right? Like not everyone installs turf the same. What's the regulation? Have they replaced it every 5 years? How many pellets are on the field? There's so many variables as opposed to grass. It just kind of is what it is. So I think there's more elements of surprise and so, but that's all you see anymore. So it's almost a moot point.
Yeah, for sure. For the people listening, what would you look for when they're looking for a surgeon, but also a physical therapist?
Yeah. So those are good questions. So I think for a surgeon, I go to someone you trust, right? I mean, word of mouth is a big deal. I tell most people that's like all I have. Like I'm not I don't get a lot of patients through the ER. I'm not fixing a lot of broken bones anymore. So these injuries are elective, and everyone knows, names in town and things like that. And so go to someone that you trust, that you've heard someone had a good experience with, or you can look up their credentials. But honestly, Des Moines is it's a good medical town. Like, I'd be lying to you if I told you I was the only one who should do an ACL in Des Moines. We have so many good ACL surgeons. So go to someone you trust, and when you meet them, if you have a connection and you feel like they care about you and what you're trying to do, then it's a home run. I think you want to go to someone that does the surgery frequently. And we all get annoyed with how many of these do you do? But you don't necessarily have to ask that question, but you can kind of figure out when you're talking to someone the process. Like, if it's a well-oiled machine, they're thinking about it a lot, right? And the more details you get, the more nuances they've been through. So those are things I would look for. Like, you don't want it to be something that's they're losing sleep over the night before. You want it to be something that's routine for them. And then don't stress over the graft. Like, if the surgeon you go to says, "Hey, I use hamstring," and you like him, do it. Like, he's going to do a great job. He or she's going to do a great job for you. So to me, that's what's important. Like, the team approach, feeling you have good rapport, and understanding their background. Is it something they specialize in and they really enjoy? Because if they're passionate about it, they're going to care, right? And then as a
Absolutely.
physical therapist, that's a big deal in a way different perspective. So, like, you got to figure out, can I get along with this person for the next 9 or 6 months, 5 months, right? I
Right.
mean, can I have
Yeah.
are we going to be able to BS about anything in the world while we're getting some work done? Do I like this
Right.
person? And then, like, is this person kind of cutting edge? Are they reading about, similar to the surgeon, are they reading about new techniques? Do they have goals outlined for me? We always send I try not to insult therapists like yourself in town. Like, when I send a script, it has broad strokes, but like, a lot of people are like, why didn't you say, 3 paragraphs worth of things? I'm like, well, if I give them the diagnosis and the procedure we did and some parameters, if you go to a good therapist, like, and they know what they're doing, like, they're going to have their own. You don't want to over constrain a good therapist. You want them to kind of take it where they're going to take it. And I tell everyone, like, "Hey, you're going to be better friends with your therapist every time I see you. Like, I hope this is your person, because you're going to see them twice a week." And so those are the things that I think are important, like figuring out, like, are we on the same page here? Do they know my goals? Do I enjoy being around them? And are they holding me accountable? Because they can't be with you all the time. And if you don't work at home, as you know, the results aren't quite as good. Those are kind of the main things I would say that are important.
Yeah. Love it. I would agree. Jason, is there anything that we haven't talked about that you want people to know?
No, I mean, this is a pretty good all encompassing discussion. And no, I appreciate your time today. It's been a lot of fun. I could talk the rest of the night, to be honest. I love talking these things.
Yeah, no, that's great. I agree. I could keep talking about it as well. But if people want to learn more about you, they want to find you, how can they do so?
Simple. You can I mean, I'd give you my cell, but that might lead to problems. I give most of my patients my cell that ask for it, which honestly, I guess I want people to know that, like, my thing is, like, I really don't, like, when I go home at 5 o'clock, the workday is not over. Like, there's all sorts of texts. I call people. I'm kind of always trying to do the right thing in a concierge fashion for people. You can schedule an appointment online through Luma at DMOS and ask for me or one of my PAs directly. And then anyone who has to schedule with me, they can. Like, there's no, like, screening. Like, you don't have to go see primary care. You don't need a referral. Honestly, I see people for shoulder, knee, hip, primarily discomfort, and elbow. So I mean, like, I'm fairly accessible, honestly. Maybe I should be less accessible, but I'm happy to see people anytime. So they call DMOS, schedule with me if they need. But yeah, that's kind of the main routes to get in and see us.
Perfect. Well, I appreciate your time. I know you're busy. Thank you for doing this.
Well, hey, thanks for inviting me. I appreciate it very much.
Absolutely.